Awesome. So yeah, let's dive in with introductions. I can start. I'm Josh Mandel. I'm a physician and software engineer working on data standards and working with Brett on the Argonaut project, where one focus this year is CGM data.
Wonderful.
Awesome. I'm the Argonaut project manager, and we've taken a few runs at writing data back into EHRs, and it's a tricky challenge, but we've got good momentum this year, and I think the CGM is a great one that we're going to make progress on this time.
Wonderful.
And I'm JP from the Commons project. We make an app called Common Health that's sort of like Apple Health, but on Android devices, and do a variety of work in the patient access and interop space. And we're a happy participant in this upcoming Argonaut project workstream, and just happy to be here and mostly listen for my sake.
Excellent. Bill, you want to kick us off?
Sure. My name is Bill Zeller. I'm a product manager here at Tidepool. And yeah, I've been working on the EHR integration piece, specifically with Zelf. So, and we're beginning talks about starting our own Smart on Fire app. So excited to share what we're up to and learn from you all. Rea?
Rea, can you hear us?
Yeah, sorry, my internet just decided to have a hiccup. So is it my turn?
Sure.
All right. So my name is Rea Rostosky, and I am another product manager at Tidepool. I worked on our EHR integrations with Redox, and yeah, definitely looking forward to talking about the challenges we've had as well as opportunities. And yeah, I'll pass it over to Kelly.
Awesome. Yeah. So I'm Kelly. I lead our product and user experience team, or as vice president here at Tidepool. Been with Tidepool for quite some time. Josh, I remember meeting you back at Fire Dev Days a million years ago now, but glad to share more about Tidepool as a whole. And then, we've got the right folks here to talk about our current EHR integrations and also what are the challenges and what's missing. So Tidepool is a nonprofit organization. We are unique in that we deliver software as a nonprofit organization to support people living with diabetes and their clinicians. We have supported over 700,000 people living with diabetes and their care team members, both care partners and clinicians. We've supported over 3,000 different clinics across the country and worldwide. And we have about 20,000 clinicians that have used the platform, or clinicians, or I should say clinic staff that represent endocrinology, primary care, MFM, and all of the wonderful staff that support diabetes education and various different MAs that support people living with diabetes. And yeah, this is a really big challenge. How do they understand and interpret CGM data? We're seeing more and more of these devices now that are expanded coverage is supporting more and more of these devices being able to be accessed by patients. And that means that there are not enough endocrinologists that can support them. Now there are various different other providers that are supporting them, namely primary care. So we do see a need to streamline the workflow, not only for the clinicians that use kind of aggregated solutions like Tidepool that are independent applications, but also like how do we really fit into their current clinical workflows today? Tidepool is a data management platform. We support over 85 different diabetes devices, including CGMs, insulin delivery devices like insulin pumps and blood glucose meters. We support devices uploaded directly using a USB cable for those of you that are aware that's for our uploader software. And we also support cloud-to-cloud integration with various different CGM manufacturers right now with support with Dexcom, with a variety of different models that they support. And we're seeing more and more device manufacturers moving to cloud-to-cloud or mobile app support for patients. And yeah, I'll stop there. What else did I miss about Tidepool in general, Bill, Rea.
No, that sounds good.
Yeah, I mean, I might just cite as well that a lot of our health systems are interested in leveraging RPM CPT codes for remote monitoring. So now that they have access to this CGM data and there's an opportunity to write that back continuously in some summarized form in the EHR as well as visualized in Tidepool, there's more interest in that. And so we're looking at supporting that as well.
Yeah, absolutely. And our data platform essentially is an aggregator. We standardize all of these diabetes devices and display it in various different forms and interactive visualizations in an independent, application. And then we have obviously these summary statistics that are coming from different devices. And we also have PDF reports that also right now are part of our EHR integration offering that gets sent back. So we have a visitor. That's awesome, JP.
If I don't let him join, he'll just make noise. So. I figure the visual is better.
I love it. Sure, like one of my wonderful colleagues on a day-to-day basis, our pup is sure to join us any minute.
So this is a super interesting overview. Thank you for the 10,000 foot perspective. I'd love to see if we could understand a little bit about how patients come to use Tidepool maybe in the first place. Maybe there's several different workflows there, but do you mind sort of walking us through what some of the most common routes might be?
Who do you want to explain this, Kelly? I can explain this. Okay.
You offered yourself up.
Okay. Whoever speaks first. So our patients primarily come to Tidepool via their clinician. So most of the accounts are actually created by the clinician. That includes provisioning whatever devices need to be connected to that patient account, can include that. So like for Dexcom, the clinician actually creates the patient account and sends a request for the patient to authenticate using their Dexcom credentials so that we can also see that Dexcom data in their Tidepool account. So that's very seamless. That's in the Tidepool web app. We also have an uploader application that we're moving to also be web-based thanks to Chrome Web USB protocols. And the third method that is also new is actually provisioning those accounts via the EHR. So with Redox, it is an orders-based workflow where they just can submit an order. It either creates a new account in Tidepool for the patient if they don't exist, or if there is a match, we do the patient matching. Xealth works similar in that regard. So that is, again, covering the clinician side, creating the accounts. Of course, we do have patients that also have their own Tidepool account already and then come to Tidepool, and they are able to share their data with their clinician using a share code. So each clinic has a share code that when provided to the patient, they can enter that on their side while logged into the app. And then they can be stored in that clinic workspace in Tidepool.
Yeah, so about 85% of our patients are initiated. They initiate from the clinician, inviting the patient to Tidepool or creating an account on behalf of the patient in Tidepool. And then about 15% are patient initiated.
Excellent. So in that 85%, kind of that most common case, the clinician will create sort of an account or maybe like the entry point for an account that a patient's going to use at Tidepool. Will they also do something around provisioning and connecting a device there? I think you hinted at this, but I just want to make sure I understand kind of what the options are within that space.
Yeah, and to be clear, the patient, it is bring your own device. So the patient has a Dexcom device. They're not prescribing the actual device in that case. We do anticipate that could be another route in the future, like with Tidepool Loop, for example. That's something we're also building. So we want to make sure that we allow the ability to prescribe that as well via our platform. But generally, it's bring your own device. And by getting the patient, by selecting for the patient to connect their Dexcom, that just helps form the linkage. So we don't have to question, which device belongs to which patient. So.
Got it. So in that bring your own device model, like by the time the clinician is helping create a Tidepool account for the patient, do they typically already have a device, or is that one of the steps that they're taking when they're just first onboarding, and then they're going to go to the pharmacy and get started with the device after that?
It's really dependent. You know, we support type 1, type 2 diabetes, gestational diabetes, you know, diabetes in pregnancy. So we support the patient that's newly diagnosed that may not yet have a prescription. They may create a Tidepool account on behalf of that patient and then await the device prescription. I would say that's less common when they create the Tidepool account. Usually they're already set up on a device. Some of our clinics want a supplied device model as well. So they are interested in a device supplied model. That's not something that we currently support, but it is a request on Tidepool sometimes. So usually the patient already has the device prescribed in or on body.
And in that scenario where the patient already has the device, they'll make a Tidepool account. Tidepool will present a list or a prompt of some kind saying like, hey, do you want to connect your Dexcom CGM? And then the patient will go ahead with that.
That's right. Yep. They'll be prompted to go through the authentication workflow, and that essentially presents the Dexcom UI that a patient logs into, and then the two accounts are linked.
Cool. So under the hood, that's like an OAuth workflow that Dexcom is being the server for, and Tidepool is the client.
Yeah.
Mm-hmm.
Yep.
Okay.
And we're storing that data, you know, where it's essentially, we are storing that data, pulling at least the last 90 days so that clinicians can perform their data review in Tidepool directly. Okay.
And is Dexcom the only CGM vendor that Tidepool is integrated with today?
We support Abbott Libre as well, the current receivers for Abbott Libre 1, and we support the older versions essentially of the Abbott Libre device and are working with the device partners to support cloud to cloud as well.
Okay, so the Libre 3 is not something you currently have, but there's like work in place to get that connection up.
Yeah, we're continuously working with all of our device partners to support the latest devices and get agreements in place to allow us to support those devices, Abbott being one of those.
Got it. And so in terms of the data that Tidepool will pull in from various sources, I mean, let's just focus on CGM for this conversation. So that might mean data that's flowing from the Dexcom cloud service backend into Tidepool's presumably cloud service backend. Is that right? That's sort of that synchronization is happening behind the scenes once the patient approves that flow?
Yes.
And can you tell us a little bit about kind of the scope and scale of data that flows?
Yeah, so we receive data we get data every 5 minutes. I think we're pulling though about every 45 minutes. We're pulling Dexcom server to get the latest data. We're receiving continuous CGM data that's sampled at the 5-minute interval in the case of Dexcom. It goes through a data deduplication process, and then it's displayed. I think, and right now there's a 3-hour delay on Dexcom side, and they've reduced that to an hour, so it's not real time. But yeah, what else to add there, Kelly? I see you're linking some things in chat.
Yeah, just linking in case you're interested in seeing all of the CGM devices that are supported there and how they're supported. If you click the link, you can see the specific device and then how that device is uploaded.
Awesome. Yeah, this is a great list. And so in the Dexcom scenario, like roughly speaking, every 45 minutes, you get, let's say, 9 more readings, which would be like the 5-minute readings for the last, it's not the most recent 45 minutes that you're getting, it's maybe from an hour to an hour 45 ago, and then you just sort of have a trailing window. Once you get those data into the Tidepool platform, at that point, they're sort of immediately available for patients or clinicians to see if they want to. Is that right?
Mm-hmm.
Yes, they are available in the patient data views. And we also have a summary service. We don't have our back engineer here, but I'll explain for him. So we, for each patient, We are also calculating summary stats on a very regular basis as soon as we get new data. And that is displayed in our population summary dashboard. And those summary stats are what we then send to the EHR, both on demand by clinician request, as well as at a defined cadence to support remote review. They currently show up as in-basket notifications in the EHR, but that summarization process is quite complex, goes through every patient that has a passive connected device. So we're always getting the latest summarized data in addition to just the raw stream of data.
And when you send those notifications that wind up in the clinician in baskets, are those, they're patient specific and they're kind of holistic? So if a patient has several different kinds of devices that are all sort of contributing information to what Tidepool stores, the summary report is about all that stuff.
Yeah, so we have, like Kelly had mentioned earlier, we have a PDF that is visualizing both the CGM data, the BGM data, any insulin pump data that we have in our system. And then what is currently sent to the EHR right now is only the CGM summary stats, as well as BGM, some summarized stats. That is what we calculate now. We want to add insulin data to that later. And as far as what is summarized, it's what's the average glucose over the last 2 weeks? What is the CGM wear? What, what percentage of time is the patient spending in range from 70 to 180 milligrams per deciliter? It's those high level stats that the clinician needs to both document a visit, as well as in our population health dashboard, for example, we actually flag. You can filter and sort patients who are not meeting glycemic criteria, for example. So those summary stats are very relevant clinically.
We can also screen share if it would be helpful. I don't know.
Yeah, that would be super helpful, because it sounds like there's a few different places where the kind of information might show up in front of clinicians.
Yeah, and Bill, I saw you were about to say something before I interrupted you.
Well, I could get into the exact, list, or we could send that afterwards, the list of fields that we're calculating summary stats for, if that would be useful, just to kind of, maybe it doesn't make sense to read them off now, but I'm happy to circulate that after the meeting.
We can certainly screen share that slide if that's what you've got pulled up, and I can
Sure.
I can also screen share what Rea is discussing on our app side. So I'll just screen share our demo environment here. This is Tidal Wave Health System. We've got lots of we here at Tidepool like our C name. So James Zeller is our standard account that we'll take a look at. But Rea, do you want to go through like what this is and talk through what the population health view is, and we can then take a look at the patient data view.
All right, yeah, sure. So this has a list of everyone in a clinic workspace. We kind of mentioned that concept of workspaces, and you can see, again, you can add patients directly here, and you can provision their Dexcom device here. So this is kind of what we went through earlier, but now you can see it.
Yes.
On this dashboard, you can see when data was last uploaded. So this is demo data, but if you have someone with a continuously streaming device, this would always be today. So that's really useful to see how recent is this data. We have tags you can apply to filter and sort your patients. We also have, yes, these columns for CGM. So GMI is calculated from the CGM data. It's kind of a proxy for A1C. Time in range is visualized here. If you actually hover over there to, if you hover over here, you can actually see the percent in each range. So time in level 2, level 1 hypoglycemia, et cetera.
These are over like the past 2 weeks by default. Is that right?
Yes, and you can change. Well, so this is 30 days right now.
I see that. Okay.
You can change that to the last week. We also have what Kelly was trying to show earlier, this percent time in range filter. So you can, if you only wanted to see, for example, the patients that are hyperglycemic in this case, you could do that, and then focus whatever remote outreach you might want to do. just for those patients. And then since Tidepool has a long history of before CGM supporting BGM patients, we support a ton of BGMs, and we display that data here as well, summarized. Any questions about this before we go to the data views?
No, this is super helpful to see.
Okay.
So this is an individual patient's chart here, and there's a number of different data views that are available for, looking at insulin data, looking at carbohydrate information that may be entered in via an insulin pump. What is the insulin delivery schedule that's happened? And then what is the tracing from the glucose? There's certain trends views that you can see. And then the summary statistics that Rea is talking about are available on the sidebar here, and we'll talk. Bill can show what's actually sent to the EHR from kind of a summary stats perspective. But essentially, this shows the same time and range, average glucose, total insulin delivery, time and automation, time and activity that are stats from the insulin pump that are very helpful for clinicians and people living with diabetes and making therapy settings adjustments. And then we have a number of different reports that are available that are PDFs. And this is also a part of the offering that we'll talk about that gets sent directly to the EHR. So AGP reports, various different, very similar to what you're seeing in the web-based interactive interface. This the basics view, daily charts, which show kind of a stacked view of a period of time that's selected. And there are settings from the pump that are also available. So all of those types of reports are also sent to the EHR based on the cadence that is defined by the clinic.
And just to make sure I understand, the PDF that you're showing on the screen now, it includes an AGP, but then also like lots of other content on subsequent pages. Is that right?
That's right. Yeah. We have the AGP report for continuous glucose monitor. So this particular demo account has a CGM data, but there's also BGM data if that is more relevant for the patient. So the BGM data report, and then basics data view. So it's more information based on really insulin delivery devices and additional details so that it supports a review and optimization of any potential changes that the clinician and patient need to make in concert together.
And when you're sharing reports back with the EHR, is this a sort of good example to have in mind where you'll share one report that internally inside of the PDF, there might be several different topic areas that are covered, or are there scenarios where this kind of gets broken down into different submissions?
Yeah, do you want to talk through that a little bit, Bill and Rea?
Sure. Yeah, this report that you're seeing does represent, if we have data to populate all of these subsections, that's what we send. So there's different workflows for our Zelf integration right now. What we do is we find for that patient their most recent 14 days worth of CGM data and their most recent 30 days worth of blood glucose meter data, and then generate a report kind of on the fly with the latest data for the clinician to view. The Redox integration works a little bit differently. These reports are generated at a set cadence. We're also working on having them triggered by a new upload. So whenever new data is uploaded, we'll be able to send a PDF report right into the EHR with a slightly modified workflow for example, Dexcom data, because we wouldn't want to send them every 5 minutes. So we're still going to have like a 2-week cadence for those particular devices to not overwhelm the providers. So yeah, this is a good representation of the visualizations that we're currently sending to the EHR.
Excellent. And we had a chance to talk with the team from Redox, so we understand a little bit about the kind of integration services that they're providing in this space. Can you say a little bit about Zelf? Should we think of them as kind of another entity in a similar space, or how should we think about that?
Yeah, sure. Yeah, Zelf has their own Smart on Fire app. And then for third-party partners like us, they've got just kind of more user-friendly web APIs that they expose to allow us to communicate with Zelf, and then Zelf does the provisioning. They hook up the HL7 V2 connections with the health system. They set up recommendation rules with the health system. It seems to me, I haven't dealt a ton with the Redux people, but it seems like Zelp takes more of a kind of full service approach and gets into the workflow design with the health systems and tries to abstract away any of the complexities, especially around HL7, from us, so that we can kind of communicate. And then once we develop an integration with one health system from Zelf, we can be much more efficient for the second through however many. So yeah, that's kind of what Zelf is offering to us.
Got it. And you mentioned they have a Smart on Fire app, and maybe you've been looking at this. For the kinds of patient level and population level views that Tidepool has today, are there, right now, clinician-facing experiences that happen inside the EHR, or is it always sort of pop out into a separate web browser?
I guess in Zelf, what we currently have, so we've done one integration with them so far, and the workflow that we built includes enrollment. So the clinician can enroll a patient for monitoring and set up, provision a Tidepool account in one form. The order gets created. There's some additional information that we collect through this pre-order form flow. So this particular health system was very interested in making sure that they got the right email for the patient. So we have an email field. We allow for tags to be applied in that flow. And we also allow the connect with Dexcom flow to be kicked off from within the EHR. And then once a patient's enrolled, so that's kind of like the order part. Then there's a monitor workflow where then the clinician can visit the patient's chart, look in. It's called the digital formulary. That's kind of the section controlled by the Zelf app. And what they see is a little tile that has an indication of when the latest data was uploaded. And we're also tracking when the last time that clinician viewed the data was. So potentially we can save a click if somebody has viewed the data, and they see that there's nothing new since their last viewing, no need to go further. If there is something new, then they can click an open button, and what opens is that PDF report that we've shown, open in an iframe inside of Zelf. So they can navigate it, they can print it if they need to, and put it in the media tab. Hopefully they get the information right there. But yeah, that's kind of what it looks like right now.
Cool, that makes a lot of sense. And it sounds like right now they can click to open up the PDF in an iframe. Maybe there's some future story where they could launch the interactive dashboard in a similar way.
Yeah, Rea, you want to talk about that?
Yeah.
we have some follow-up calls with you all if you're interested.
Yeah,
this
for
is
sure.
our main problem right now.
Yeah. So the reason why we are working on our own Smart on Fire app is there are some concerns with security when you're going through one of these third-party integrators and launching, their own Smart on Fire app. I believe, basically they're storing a token that they maintain that, is vulnerable to being exposed. So that's why we're going with our own Smart on Fire app to launch our data views that we just shared earlier, the individual patient data views. But it's just the same thing as Tidepool. It's not a separate UI that we have to build.
Yeah.
And I'll say we wanted to be able to support. We have some health systems that really want to use Fire and not HL7.
Mm-hmm.
So that was kind of what actually started leading us down this pathway, is that they really wanted to use Fire. We've talked to Redux, we talked to Zelf, and they're not able to write back that discrete data that we were just talking about because there's very limited ability to write back data using FHIR standards. So we thought, let's build our own and maybe that will work. Still having challenges, and that's just because FHIR is not event-based, and it requires the clinician to perform some action, requires there to be an open encounter. So we're very limited in what we're able to do. And it turns out with Xelth and Redux, they have the same challenges. So right now, our approach with FHIR is it's just an app to visualize data in the EHR, which is definitely serving a great need. But we'd love to, obviously be able to send that data back as well. I think where Xelth and Redux provide a great service is that HL7 is so complicated and such an outdated standard. But if we were able to use FHIR, we could just have our own Smart on FHIR app and do everything directly.
Yeah, so I mean, this really is the center of what we're looking at this year for the Argonaut project is what are those write back capabilities that would make sense to expose in a consistent way using FHIR across different EHRs. And I mean, I'd like to explore this with you from a few angles. Maybe the simplest one would be like, if you could wave the magic wand and configure these EHRs so you could write whatever you needed to into them whenever you needed to, and that was just sort of possible now, what would you want to be able to write? And how often, like how would you define that if it was totally up to you?
Yeah, I think, are you familiar with the ICODE standards? I think we're familiar on what types of data should be written back. I think we have a good sense of how often that data should be written back, but I do think clinicians should be involved as well. I think there's not a great standard for what action needs to take place in the EHR, if any, if they are receiving this data in some regular cadence. So that's definitely a piece that needs to be factored in. If we are going to be sending this data back, what is the appropriate cadence? I think it's been met with fairly good reception to do it about every 2 weeks, every month. That would correspond to the RPM CPT codes where you can bill a patient maximum once a month for CGM data review. But yeah, Kelly, do you want to talk about the ICODE standards?
Sure. So have y'all heard of this yet?
Yes, so we've read the report. We've tried to reach out to a couple of folks who were involved in writing it, and we've not yet successfully been able to connect, particularly on the device vendor side.
Yeah, we'll get you introduced.
Awesome.
Juan Espinoza is the co-chair, of course, with many other clinicians. There's two parts of this project. The first part was the ICODE 1 project that essentially supported CGM data. We're now working on ICODE 2, which is insulin data. So, how do we come up with the right clinical workflows? I think part of the reason that Rea is recommending clinicians be heavily involved in this is with our Redux implementations for EHR integration. There are just so many ways that clinicians want to be able to see this data and order it and where in it falls in the EHR and how that's visualized specifically for the discrete data right back for like CGM data. There's a variety, and even the PDF reports, there's a variety of requests that we get, and we're trying to standardize our offering as much as possible, but that still, I think, doesn't have a clear consensus. And so part of the ICODE project is to develop the recommended guidelines on the workflow side. They have like a clinicians and a data standard side. So Dr. Klonoff and Dr. Espinoza are good folks to get in touch with. We can introduce you all if you haven't met before. And then we can also make some introductions with the device manufacturer side as well. The ICODE CGM metrics, like we have the standard metrics that are written back. I know, Bill, I don't know if you want to screen share that PDF.
Sure,
but,
I can do that.
Share with you as well.
Here we go. All right, you see that okay?
Perfect. Yep.
Yeah, so here's the BGM statistics. These come, these are very much in line with the ICODE core metrics that they recommend reporting. So I'm sure you'll be familiar with all of these. Yeah, and then the CGM statistics are fairly similar, just with some, time below range, time above range, things that aren't able to be communicated by a BGM by itself. So yeah, these are the stats that we're currently writing back in our initial EHR integrations. We're looking to potentially expand these, but yeah, this is sort of like the basics.
Yeah, so it's essentially the same data that's powering our population health views and the population level statistics. They are similar to what's available in the sidebar, excluding currently insulin stats, which is what we're working on with the iCode 2 project to define and then implement as well.
So the statistics that we're looking at here are similar to the kinds of facets that you can do from that summary dashboard, but obviously a lot less detail than goes into like some of the visualizations where you can see, day by day what the overlays of the CGM traces look like. For these summary data, are they also reported in 2-week periods, and can those overlap, or how do you work through that?
A lot of deduping.
Yeah.
So essentially it depends on the cadence, but essentially looking at for GMI to be calculated, we use 14 days. That has to be, a sufficiency. There's a sufficiency requirement on how much data is required to generate an appropriate GMI level. And then based on the cadence of when we're supporting these stats and the PDF reports to be sent. Usually right now, as Rea mentioned, this is like 2 times a month, every 14, 15 days. Correct me, I'm not sure which one, but essentially sending data back twice a month and on an order cadence as well. Like if a clinician wants to see that data immediately, they can also order and then pull the most recent data.
And that ordering kind of workflow, just to make sure I understand, like in the background, you might be sending a report in, or sending a set of summary data into the EHR every 2 weeks, but a clinician is going to have an appointment with the patient, and before that, they want just sort of the most up-to-date report. Is that sort of the scenario for that on-demand?
Yes.
And how would they request that in their workflow?
Yeah, we keep it very simple. There's basically a start diabetes device recordings order and a stop diabetes device recordings order if for whatever reason you didn't want to continue receiving that periodic data right back. And anytime they want to get the latest data, they can always submit that order again, and it just shows up as another row in their flow sheet.
So this is a scenario where they may have an ongoing order that's been creating new rows in their flow sheet every 2 weeks. And at some particular moment in time, they think, I want the most up to date. So they'll sort of start a new order and then maybe stop it right away to get that row kind of transmitted.
Yeah, they really don't need to use the stop order, but I think what you're hitting on here, which is an important point, they would be starting a new order. So the way we're able to continue filing back that discrete data periodically is it's a standing order. So it's attached to that initial order that was on demand. And, but yeah, that's basically enrolling them right in this discrete data write back. If they later want another on-demand order, it doesn't unenroll them. And so, based on whatever the cadence is, let's say the patient's due to send data again in 3 days, they're still going to receive that data in 3 days. We're not altering that cadence because it's a batch send for every patient at that clinic that's enrolled.
Got it. So the batches happen all aligned with each other. If you're seeing 100 patients in Tidepool, you'll get your inbound data happening twice a month with updates for the 100 patients. Their actual windows of when they've been wearing devices for could be overlapping in all kinds of different ways. But you present kind of a unified 2-week stamp.
Yes, absolutely. And we'll show data sufficiency. So if the patient started midweek, you'll see their CGM wear was 69%, for example.
Sure. Okay. Or you might have 99%, but spanning 2 different CGM devices that went into the report for that patient.
That is may be true. Again, we do some data deduplication. So, so that whole sufficiency calculation, it would be like, I don't think we would double count that section.
Sure, right. Oh, no, I was trying to say, like, if they switch devices halfway through the week, like one patient happens to have switched devices halfway through the week, you would figure that out and join the data together to say, you actually had good 2-week coverage. It just happened to have been split across 2 devices.
Yes, absolutely.
Yeah,
Okay.
we standardize all of the diabetes device data. You know, let's say they just have a Dexcom connection through the cloud-to-cloud integration, and then they have a Dexcom connection integrated with a Tandem device, and that upload happens. We make sure to only support the data that's essentially that continuous standardized data for that patient over that time period, over that 2-week time period. So there's sometimes multiple sources of CGM data that can happen at once. That's common in diabetes care. Even with the same device, there may be multiple ways that device can be connected to Tidepool.
And to explore the ordering and submission workflow a little bit more, if there is a standing order for a set of patients in a given health system, how does Tidepool get that order information? Is that coming through like Redox and Zelf, and they're supporting that communication for you?
Yeah, they basically just send us the order ID and we reflect that back to the health system, and that same order ID tells the health system then where to put that data, that's tied with this order. Okay.
And when you are managing a set of orders and every 2 weeks you're going to be sending a new update to the health system, the data you submit to the health system are tied back to those orders. And you submit again through these integration vendors or through different channel?
No, it's through the integration vendor to translate it to HL7 every time.
Okay.
So they probably take that order ID. Yeah.
I will say we are managing that queue though. So if some health system said, hey, I only want to see patients that are greater than 1% time below 54, only send me those patients, those could be later iterations because we're managing that part of it, the integrator.
But is that something that can happen today? Health systems can decide to filter their support ports?
We have not built that today. I think we also offer so much more in Tidepool that there's at some level where it doesn't make a lot of sense. Once you receive all those patients in your EHR, well, who are you going to look at first? If you have 100 patients that are less than, greater than 1% time for 54, right? So the prioritization piece is challenging in the EHR. The visualization is, yeah.
We could maybe magic wand. That would be great. If we could, replicate some of the functionality and care models that clinics have within the EHR around the diabetes device data. It's much more used currently as a reporting mechanism and as a single patient view mechanism rather than looking at a prioritization of patients and then supporting any type of remote monitoring workflow that is based on how well is my patient doing? Do they need outreach? Do I need to intervene between now and the next visit? The current workflows are built for an inpatient, in-person visit with that patient. And that's, just historically, I think where clinicians are looking for this type of data, those types of workflows that really support the care model of proactive interaction with diabetes device data have to occur right now in Tidepool. And if we wave a magic wand, I think especially as more and more devices are prescribed and there's expansion into type 2. Now there's over-the-counter Dexcom device, the Stelo that was just approved, which is wonderful. We're going to see more and more patients that want their support from their clinicians, and they want to be able to have that interaction. And the workflows that we're talking about right now aren't supporting that type of care model. They're really built to support the one-to-one in an exam room, looking
Yeah.
at the patient's data.
Yeah, I mean, I wonder if we can talk a little bit more about both the sort of the incentive structures and the workflow changes that we would need in order to make that transition. We talked a bit about reimbursement for remote patient monitoring. Can you say, like, what, from a workflow perspective, is it important that this sort of population level care and then drilling into remote monitoring, is it important that that happens in the EHR, maybe for technical reasons or maybe for billing purposes, or, you know, why not just sign into the Tidepool portal and do everything from there? Can you talk us through the way you think about it?
Yeah, Bill, you want to jump off on this one?
Well, I was going to say, we've heard a lot of requests for the billing piece to happen in the EHR. It sounds like a lot of individual health systems, you know, billing departments have various requirements that, you know, you've got to document whatever you've done for 95251, for example. You may have to have certain statistics included in the patient's chart in order to create a billable encounter. In addition to any, you know, treatment changes. So to the extent that, you know, smart phrases or some of that data could be automatically or either automatically populated into a chart or done, you know, much more quickly, I think that that would be a very, you know, strong value for health systems who are trying to begin to capture some of these remote patient monitoring codes and generate an ROI for that.
So it sounds like there could be a role for EHR integrated remote patient monitoring tools that offer the workflow of remote patient monitoring in a really domain specific way, the kind of stuff that the Tidepool has built a lot of already, but then hook into the EHR to sort of emit the billing oriented details or the specific granular documentation that's going to be needed to interface back with the world of insurance. Is that roughly the way you're thinking about it?
That's kind of how I think about it right now. Yeah, like just the nature of the way people use EHRs right now seems not so, you know, well suited for population health and for more remote patient like the actual triaging and the categorization of patients and comparing them and you know, viewing their data and performing the reviews. All of that right now, at least, can happen much more organically, I guess, in Tidepool. But the billing event, that documentation piece, does still need to be done inside the EHR. So yeah,
I'll say billing and patient communication right now as well.
True. Yeah,
that's a key part of it.
That's a great call out. It's interesting, like there's aspects of patient communication where Tidepool already has an open channel and, you know, where there might be very clear ways to reach back out. But when it comes to patient communication around reimbursable aspects of care, the requirements for either documenting or sort of auditing that channel become really important.
Absolutely.
This is really interesting, and it's a theme that has not come up in our other conversations around how to plug into the reimbursement system effectively and where the divisions of control would sit. Is that something that is being discussed or worked through in detail in the iCode space, or, you know, what's the right community for working through some of those issues?
Well, absolutely. So the iCode space is definitely talking about, you know, what necessary data has to be in the EHR to support reimbursement, and looking at the RPM code specifically and some of the supporting codes around just visits as well, virtual visits as well. iCode is certainly working on it. I think we are working on that with certain health systems. We have a project right now with Stanford that Rea can talk a lot more about, that's based on a CGM, essentially looking at a remote patient monitoring workflow for algorithmically enabled monitoring of patients based on hypoglycemia risk and loss of CGM data, and we're working very closely with them to optimize how we structure the patient communication and the necessary information that needs to come into the EHR for that to be billable, and to support the care model that right now they're seeing, with the introduction of this 4T care model, they have seen 0.5% A1C reduction. With the latest that they'll be publishing even a greater A1C reduction in this care model. So, there's such a value and a tremendous value on a patient outcomes perspective. And that type of care model, should be supported by the right incentive structures and the right reimbursement structures, so that type of proactive outreach can be supporting that endocrinology practice. So, we're glad to bring you into those types of discussions if interest. I know the Stanford team likely would be very interested in the Argonaut project as well. So, Rea, anything else to say on that?
Yeah, I think we're early in our discovery of what is required for billing, but my sense from talking to Stanford is there's not standards for what documentation needs to be submitted. There's a whole billing compliance department that you have to go through. As we get into some of the more complicated codes that actually require tracking time spent with a patient, there's even less standardization there about what proof do you need to show for that time. So I think it's a very interesting space, and yeah, I hope we work together more on that.
Yeah, likewise. I should say we're going to be launching this Argonaut project in the beginning of May, and we'd love to have participation from Tidepool, but also introductions if there's others that you think would want to be involved. Our focus really is going to be around the EHR write-back APIs, but obviously this introduces a whole set of conversations about enrollment and onboarding, integration of tools, as well as potentially hooks into the reimbursement space. And it at least requires some understanding of the clinical workflows, because writing data into a big empty pool in the EHR is not going to be what really moves the needle. It's going to be writing data back that can get used downstream. Let me just make sure I open up for Brett and for JP. I've been going through a whole series of questions, and I think I've had answered all of them. So thank you so much. Let me see if there's other questions from our side.
No, I'm just looking through our list. No, this has been great. The billing piece definitely is something that has not come up, and I'm still just kind of trying to rack my brain around like how, even after write back, how that would be done outside of the EHR directly. But it's another thing to think about in this complex orchestration of getting data in the EHR.
Yeah, absolutely. Everyone's learning together for sure. As far as the Stelo device, I see your note in chat. We are continuously working with our device partners to support the latest and greatest devices, including those that are, supporting patients even off requiring no prescription. So,
yeah, I think that's going to be an interesting new world. But I'm certainly interested in giving it a try, right? And as I'm sure many others who are curious will as well.
Yeah, I mean, I emailed my doctor asking for a Libre 3 prescription just to sort of play with it, and my doctor was happy to write a prescription for it. I don't think she necessarily expects to or wants to see any of the data.
Yeah, absolutely. That's also the other thing, with data in the EHR, is there a risk of overburdening providers and having this data require interpretation? We see clinicians also express risk that should we show alerts and alarms within? So right now we store alerts and alarms events in Tidepool's backend, and there is a potential concern from clinicians about liability and what happens if there is data available in the EHR and there was no action taken on something that was out of range, or an alert or an alarm happened. And so that comes up quite often in our discussions, like, are there downstream implications to having this data available that where action may not be taken.
Yeah, I mean, this is something that even came up in our Argonaut project on writing vital signs into the EHR. You know, you see somebody's blood pressure is spiking just as part of a daily measurement that's been flowing in through a remote monitoring situation. Yeah, being able to clearly communicate expectations so patients know whether or how the information is going to be used. This is really important, but I think that it's probably in a category of issues that are maybe more social than technical.
Absolutely. Policy and certainly, you know, what are the responsibilities of the clinical staff, and what's the understanding from the patient on how that data is being used and interpreted, and, you know, making sure we also don't overburden with too much information.
Yes.
And it's interesting that some of those liability questions, sometimes a line is drawn when the data are not housed in the EHR, even though, you know, just clicking a link would pull up those data. The fact that they're not in the EHR, but in some other vendor's cloud storage somehow makes a difference. Yeah.
Yeah, I feel like some emerging standards around, you know, what the liability concerns are, what obligations does a single piece of data actually, you know, bring about, could lend some clarity, because hopefully it's not like just having this data shouldn't expose you to liability in itself. Otherwise, you're incentivizing hiding, you know, your patient's reality. So hopefully that's not the answer. But yeah, I feel like as we're working on common standards around the practice and you know, how to deal with these new flows of data should also be part of the discussion.
Yeah, I think that's totally right. Well, thank you so much for making the time and for bringing everyone to talk with us, and also giving us screen shares and a lot of insight into what you've built. There's a tremendous amount here. We're really excited about figuring out what we can standardize, and we try to be pragmatic about that, and hopefully that'll shine through as we launch this project and start to scope it out.
Absolutely. We're so glad that you reached out, and happy to connect you with the iCode project folks. And also, you know, just, we are an open source nonprofit. We share everything that we do publicly. If you need any specific guidance, if we can help in any way, we are happy to share. Our code is open source. Our statistics that we represent, we're happy to share.
Awesome. Thank you so much.
Thanks so much.
Cool. Nice meeting all of you.
You too.
Likewise. Talk to you all soon.
All right.